Present.
Director Story, and Chair Kim is absent. For the record, those directors also present. Director Sorrell,
Present.
and also for the record, Ms. Merriweather.
Present.
You do not have a quorum.
Okay, so pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. To streamline, we've combined the action items into one combined motion, so only one roll call vote action items will be needed during the meeting. Meetings of the Cook County Health Board and its committees will be held remotely until otherwise noticed due to the determination that a public health emergency exists. So thank you, Debbie, for the role, and formally call the meeting to order, which I did that out of order, so I apologize, and we took roll. The next regular meeting of the Quality and Patient Safety Committee is scheduled for Thursday, May 18th at 10:30 a.m. Let's see, is there public testimony? Has anyone registered to provide virtual oral testimony or submitted written testimony to be included into today's record?
We did not receive any registrations to provide virtual oral testimony, nor did we receive any written testimony. And Acting Chair Garza, Director Story is present. And so you would have a quorum if Director Sorrell would be able to act as a substitute member.
Would you be so kind, Director Sorrell?
Yes, I'm happy to assist. Thanks.
Thank you. So we have a quorum. I'll move on to item number 3 on today's agenda, which is a report on quality and patient safety matters. So no action is needed for these items, only informational. We'll start out with the HRO dashboard reviewed by Dr. Mikiadis, who's our Chief Quality Officer.
Hey, thank you, Director Garza. We are going to run through the dashboard here, and as you can see already up, we have our patient experience work group reports starting off. What we're looking at here is the likelihood to recommend. This is for Stroger specifically. Top box scores. We're going to hear a little more in depth from our patient experience group later, but I am very happy to show that there's been a big increase, 65 to 77% February into March, and so that's kind of our roll-up measure. If we go to the next slide, you'll see this is so what we've done, if you remember from last time, we're giving kind of the roll-up metric, and then we've done a lot to leverage the data to really drill in on 2 or 3 things that are going to drive kind of the roll-up measures that we're used to seeing. So kind of breaking that apart, this is one of our highest contributors. It's our nursing communication. A lot of work going on there, and we've seen some really nice improvement there, 64 to 77% February into March. A lot of work around nursing leader rounding, using eye care, and then CI care as a standard of behavior. It's really kind of where the spreading the word and implementing. Again, we'll be hearing a lot more about that in just a little bit. On the next slide, we have our environment domain. Again, improving this 10 points, 52 to 62% February into March. So again, a lot of improvement, using a lot of visual management for EVS to make sure the cleaning's completed. Again, leadership rounding with the EVS teams as well. So if we go to the next slide, we're going to shift into our clinical documentation work. So here's surgical and medical. We've shared that historically on 2 slides. We're going to move this into 1 and then share a little bit more in depth behind these 2 measures. We've also increased our targets because they were performing pretty well. They've gone up between 10 and 20%. So we're up to a target of 3.3 in surgical. We're hovering right around 3 right now. And then medical is a target of 1.38, and we're fairly flat around 1.2. We go to the next slide. This is another piece of the work around documentation and opportunity is to improve our observation rates. Well, we have been seeing an increase into March up to 31%. The thinking here is that with better documentation, we're able to make the argument to payers to increase our inpatient rates, which benefits our patients as well in terms of copay. Next slide. So this is another, so this is observed over expected mortality, and again, a documentation opportunity as we look into the data for capturing comorbidities and really having our clinical teams receive the credit for, just how sick sometimes our patients can be. That presents really an opportunity to right size the documentation. If we go to the next slide. So shifting to our clinical outcomes work group. So one of the measures, this is a new one that we haven't really looked at with this group, but it's our SEP1 bundle, so sepsis compliance rate. Again, publicly reported, part of our STAR measures. And we've seen a nice trend increasing through the beginning of last year. Just to call out for January, we have been doing some validation on the data, and that's actually going to be flat at 40% December into January. So it did improve just a little bit, but a lot of work going on there as well. Engaging the clinical staff in the ED, and one of our common failure points is redrawing a second lactate. So we're looking to create an auto reflex that's going to redraw that if certain clinical criteria are met. Next slide. Another contributor is one of our hospital-acquired infections, C. diff. So last year we came in at 43 cases, and through March, so first quarter, we're at 5 right now. So if we assume a linear trajectory, we should see a very nice reduction coming in, hopefully around 20. It is still a small sample at 3 months, but keep an eye on it. But that would represent a very nice reduction there. Moving on to readmissions, still doing pretty well in the house-wide readmissions. We're meeting target just shy of goal. We're at 9.77 in December. And our goal was 9.9, our stretch is 9.7, so we fell just shy of the stretch in December. We go to the next group, or the next slide. So the readmission group is actually raising the bar a little bit. So we're looking at this again as a publicly reported measure for STAR rating, but it's EDAC, excess days of acute care. So readmissions really just look at inpatient discharges who come back and get readmitted inpatient. EDAC is actually looking at anyone who requires after an inpatient admission. So this not only includes inpatient admissions, readmissions, it includes observation stays and ED utilization as well. So it's kind of a higher benchmark in terms of how well we're transitioning our patients and supporting them as they leave the hospital after an inpatient stay. Next slide. So looking at throughput, this is a new group coming into the HRO structure. Our ED left without being seen. A lot of process change took place through the end of last year, and we see the really nice improvement of the percent of patients who are getting seen now instead of leaving without being seen. So, up in the high single, sometimes low double digits, and now down to less than 2%, which is just a fantastic improvement. ED length of stay.
Excuse me, Dr.
Yes. Yeah.
Can you just, I'm just curious, great work here on the LWOP. Can you just share with the body what intervention or interventions were involved?
Yes. So one of the things that actually came to light in the sepsis work in the RIE as well, our triage time to seeing a physician oftentimes would take quite some time, sometimes north of 6 to 8 hours if it was very, very full. And they were able to basically dedicate a clinician to what they're calling Dr. Quick. So it's a quick assessment. They do triage and they're seen by a clinician almost immediately. So we're able to now have kind of that complete assessment done as soon as they get into the triage space. So it's really driven, that left with people are getting seen, I guess is the simple way to put it, without having to wait several hours to see a clinician.
Great. So that touch, that initial touch has stemmed the tide.
Yeah,
and
it
feel like
affords,
they're being treated. That's great.
Exactly, and it affords the opportunity to really have an APP or a physician speak to the patient and really say, hey, you really need to stay. It might be a little bit, but this is what I'm worried about. So we're able to engage the patient a lot earlier in the presentation. All right, next slide, please. Thank you. So here's an area of opportunity that we're just starting to focus in on. It's ED median length of stay. So this is for ED discharges. So our patients who are being sent home from the emergency department, how quickly are we able to move through the process of care and able to discharge them home? So it's an area we're just starting to really focus in on, and something that we'll be sharing with you as we progress on the work. Next slide. Oh, sorry. that was, hold on, we're up one. Can we go back one? So this is our geometric mean length of stay. So this is our targeted length of stay based on the DRG that's assigned to the patient and our variance to that. So we ideally would like to get as low as possible. And again, this is, we're looking at broader length of stay opportunities as well as kind of those incremental within the day. How do we shave some hours off and get patients home a little more efficiently? So kind of two areas of focus there. And now shift to our last work group. This is HEDIS. So if I'm sure the group remembers, we've watched a really great improvement with the A1C trend, so diabetes control. We're moving that to a watch metric because they really knocked it out of the park. They did such a great job. We're bringing in 3 new measures now. So childhood immunizations, which kind of was a secondary measure, but we're really trying to focus in now with our ambulatory teams. Stroger, Sangstack, and Cottage Grove, represent about half of our pediatric patients. So we're really focusing in those 3 areas to drive those conversations with parents about getting their kids vaccinated. Next slide. Our next 2 are really kind of screening for, so this is a screening measure. Our next one is a chronic disease measure. So breast cancer screening for women, again, Stroger, Sangstack, starting there. We are seeing a positive trend already, and hopefully we'll see it take off in an even better direction. And then our last slide for performance is our blood pressure control. I know that's come up in discussion before. Again, Stroger and Sangstack, we're starting there. It's just shy of half of our total population in terms of a driver for improvement. So lots of work there in terms of chronic disease and screening measures. And then the next few slides, Debbie, are actually just the tactics. So I know we're really short on time. We can probably just kind of breeze through that if there aren't any questions. I see Director Story, your hand up.
Yes, a quick question regarding the breast cancer screening activities.
Yes.
Are you all inhibited by technology, or is it the individual's decision?
So I would say it's probably a little bit of both. It's not really technology. I would say more process and kind of moving people through. Now that said, there was a rather large bottleneck initially, and the team's done a lot between imaging and the primary care teams to really pare down. And when the team started looking at it, we had quite a bit of a backup, and they were able to pull that down to just a couple hundred patients on the wait list. So they did a really nice job kind of moving patients through and getting them completed. And then on the other side, yeah, I would say there probably is at times, how do we create this more, better efficiency, right, to move patients through so that they aren't lost to follow-up in a sense.
Can I just ask a quick follow-up regarding the technology?
Yeah.
That you're employing today? The mammography unit. Would you say that we have access to the current state of the art, or would you look at investing in some more advanced technology regarding, breast screening procedures? I've just heard people talk about the difficulty that some women have with certain units, especially women of color in particular, and the difficulty that they have in terms of it's not as comfortable. I've just put it that way. But I think what I'm talking about. You know what I'm talking about.
Yeah, I do. I believe we do, but let me actually look into it and come back and with a definitive answer for you, Director Story. I don't want to, overstate and then find out that I was wrong. So let me look into it, and I'm happy to come back if that's okay.
Thank you, sir.
Of course.
Okay, any other questions or comments?
I believe Director Sorrell has a question.
Yes, thank you. And you may be about to address some of these other indicators, but there have been certain recommendations regarding universal behavioral health screening across the continuum, as well as universal substance use screening. That's particularly of interest given our recent 350% increase in adolescent opioid overdoses in this past year. Are we currently screening from a behavioral and substance use perspective, and additionally with adverse childhood events for adolescents, which could be indicators not only of behavioral health, substance use, but also juvenile behavioral problems? which we certainly are aware of, or could potentially be an increasing area concerns for our areas.
Yeah, so actually, let me ask Madi, since she's really involved in the ambulatory space. Madi, can you speak to, are we universally screening, or is it only if we have a concern?
We're universally screening everyone.
Thank you, Madi.
And for what indices? Thanks, Marty.
Say that again?
And in what indices for adverse childhood events, behavioral health, and substance use screening?
I know that we have a behavioral health screening. And it does include, I think it does include those, but I'd have to get back to you.
Okay, thank you so much for that. That'll be an area that we can report that we're actually addressing our current needs that we're seeing as well in our adolescent and adult community. Thanks.
Thanks. You're welcome.
Thank you.
Okay, any other questions or comments? Okay, thank you for the fine presentation, and to my colleagues, thanks for the good questions, thoughtful questions. So we will move on to item number B, regulatory and accreditation updates, which will be reviewed by Cynthia Fish, who's the Director of Quality, Regulatory Affairs, and Accreditation.
Thank you. Good morning, everybody. Just an update for regulatory for the system. At Provident, we are still awaiting the CAP survey that's expected this year. It will be unannounced, so we are just waiting for that. In addition, we continue to report out on the mock survey with all the corrective actions, and that's performed weekly at Provident. So that is ongoing and working well. At Stroger, we are looking to have a mock survey this spring, so looking forward to planning that. And then the next slide, please. We actually have received the new 2023 survey readiness guide, and we have just completed bundling all of those packets. So we are working on a distribution plan. I'm hoping to have those out to everybody next week. Thank you. Any questions?
I would just be curious.
Comments?
I would just be curious, if there's any significant changes in the regulatory updates that you've had a chance to sort of identify?
Thank you. You know, a new standard that they're looking at Joint Commission now is related to health equity and how are we addressing that and disparities. So, but other than that, we don't. I do want to continue to send out newsletters. I am actually joining the Joint Commission Advisory Board, so I'm looking forward to being a key member in finding out information that may be, you know, for us to see and coming about. But no other changes. Thank you.
Any other questions for Cynthia?
Yes.
No, okay, I don't think I heard any. Cynthia, thank you for the presentation. Appreciate it.
Thank you all.
Okay, let's go on to item C, which is a quarterly nursing operations update reviewed by Dr. Dana Peters, who is the system's chief nursing executive.
Good morning, Chair Garza and the directors. Part of the quarterly updates, all of you have seen this slide. So nursing priorities continue to be provide high quality, safe care, zero harm initiatives to the patient as well as staff, create an effective and efficient nursing care delivery model, include workforce planning and development, improve patient experience, and improve staff engagement. Those are the 4 pillars. Next slide, please. So today I'd like to provide high-level update on nurse sensitivity quality indicators. These are the indicators that actually demonstrate the effectiveness of the nursing care across acute care. So hospital-acquired pressure injury, that is actually one of the major indicators for nursing care, and you can see that year over year the quality, the happy incidents decreased at Stroger Hospital. And actually, the total decrease is a 96% reduction since 2019. We started tracking these measures, and that took us, Stroger Hospital, Cook County Health, to be one of the top 10 percentile performer nationally. Hospital-acquired pressure injury the quality indicators. Also, an average cost of a happy incident is for $43,000 per incident. So this improvement actually contributed to a cost avoidance of over $14 million for the last 4 years. Next slide, please. This is the report from Happy Incidents at Providence. So Providence had 0 hospital-acquired pressure injuries in 2020-21. However, we noticed 3 incidents in 2023, all related to one particular patient. So we are drilling down, and also we implemented actions to prevent the hospital-acquired pressure injury, same as Roger. So the first quarter, the incident is 0. Our next step is to put the add the Providence Hospital to the national benchmark system. So then we will have also benchmarking report for similar size hospital. Next slide. The other nurse sensitive indicators is the falls and the total falls with injury. So we started tracking the falls across the system, which include Providence, Roger, ambulatory care, as well as CERMAC. So total falls reductions, you could see total fall is a 42% reduction, and also the falls with injury reduced it by 80%. Looking at the nursing practice and the standards, the falls incident at CERMAC contribute directly to the nursing care. So in 2023, we are removing CERMAC falls numbers from the future reporting. Next slide, please. So this is the falls with injury reports specific to Roger Hospital, and also a nice reduction. The total 37% reduction of falls, total falls, and an 81% reduction of falls with injury. That is the major focus on all health systems. So, and also we track this information in our national benchmark database, and you can see on this slide for the last 8 quarters, the Roger Hospital is performing the below means, which is that's what we wanted to see. Lower is better in this particular indicator. So hope to maintain that, and these indicators will help us to achieve our strategic goals of nursing pathway to excellence as well as magnet. So we are actually at those metrics to meet those standards. Next slide, please. This is one area we focus. Providence falls and falls with the total falls at Providence, seeing an increase, and the contributing factors for increases are 1, increased volume, and also some of the patient types recently at Providence related to emergency room ambulance run. So nursing is working to implement a number of actions to make sure that our total falls decrease, similar to Stroger. And also we are reviewing 100% root cause on all falls. So I'm hoping to see the hardwiring those best practices for the next few quarters. Next slide, please. The other nurse sensitive indicators is the underlying associated bloodstream infection, and you could see this is also a matrix. We have process in place and seeing a very good reduction. So a total reduction of 81% since 2019. We're tracking this matrix, and also with the national Indian QI benchmark, we are seeing a number of 3 out of 6 quarters below national benchmark on our performance. Our goal is to get to 5 out of 8 quarters consistently to meet the best practice standard. Next slide, please. Again, catheter-associated urinary tract infection, CODI, also is one of the nurses. You can see a significant reduction, a total of 8 action, and also many quarters Stroger is performing below the national means, which is great. Next slide, please. The other nurse sensitive indicators is the utilization of the restraints. This is the current study we do every quarter, and as you can see in the data for the last 8 quarters, this particular nurse sensitive indicator is performing below the national means, which is below is better for this particular benchmark. So a great job the team is doing. Next slide, please. I know Dr. Mikaitis mentioned about the nurse patient experience and nurse communication domain, the focus area for nursing. Lots of work is happening, and I know today the patient experience committee also will provide an update, but the notable improvement is that 32% increase in nursing leaders rounding on all the patients. We do have a custom question within the survey, and the survey is one of the outcome metrics we measure. So that is huge. We also implemented number of like care, CI care training, hourly leadership, and rounding. So the patient experience committee will go into details on that. Next slide. Same thing at Provident, we are focused on two indicators. One, the nurse communication, also increase the number of response rate to have a data that we can make and action. So leadership rounding 9% increased, and the focus a 60% increase in survey response is huge for us. And now we have better information response from patients. So again, the focus is to improve the nurse communication domain by implementing many tactics. Next slide, please. So this is the slide. It's from Praskeni, who owned the NDNQI, which is the National Database Indicators Tracking Benchmarking for Nursing. And you could see the overall patient safety outcomes during COVID decreased by 7 to 8%, and which is the happies, the clapsies, the falls, those indicators. So happy to share that the Cook County we are at increased those sensitive, those nurse sensitive indicators about 10%, and that is all the commitment from our frontline nurses and the frontline leaders. I really want to next slide, please. Also wanted to share the group that from other focus area for retention, there are significant acts are in motion to really improve our retention and also engage the staff. And some of the highlights are we started a nurse residency program, which is one of the best practices to retain the new nurses entering into workforce. And we had our first batch of nurses graduated last year. We are starting the next cohort in April, May this month. Also, we applied for a APRN residency extension grant for 2.0 versa to expand our existing program. Also, we have nursing retention committee. As senior nurse leaders, we meet with all the new nurses to welcome and also understand and address if they have any concerns. Also, we started a front nursing leadership training program. All the nurses across the systems are at training that really help them to address some of the challenges as well as engage the frontline staff and improve the patient care outcomes. Give them the tools to apply to their practice. Next slide, please. So this is the nursing turnover data. Is if you look at it, overall national turnover is about 20%, and it's actually got up to 27% in one. And we started tracking the nursing CCH turnover since 2001, and you can see CCH we are actually outperforming the national benchmark. We are below 10% in 2021, and close to 13 in 22. And the 2023, the first quarter, the CCH nursing turnover is 4.3%, which is one of the best in the country. Look at the other systems, and so some of the we are putting in place is truly, helping us to understand nurse turnover data and create actions. Next slide, Debbie. There are challenges also in nurse recruitment. It's not just Cook County, across the system. There was an article released last week. It's a national study show that about 100,000 nurses left the workforce during COVID, and also according to the study, 1 out of 5 nurses are projected to leave the profession or even at least the bedside by 2020. And all these changes with the last 2 years is increasing the nursing market and as well as gaps, and that actually impact us our hiring velocity. So there's a lot of work is being done with HR and nursing combined to improve our nurse recruitment hiring velocity, but also we are working against some of the market challenges. And I talked about the nursing turnover, and in short, we are projected to have 1 million fewer nurses by 2024. So those are all the challenges, and then we are also creating actions, some of them. Next slide, please. So these are the things, we have, as I shared with you, hiring, retention, and workforce optimization is one of the top items on nursing. We are not only looking at hiring, also we are, looking at some of the top of the license practice, seeing what else we can do. So more to come on that. Shared about the leadership development program to really provide tools to the frontline leaders to, to manage the nursing service, nursing work flow optimization is, we need to start look at removing some non-value added workload, the frontline staff, nursing wellness program. We will be kicking off Pathway to Excellence and shared governance this year, a flexible staffing pool plan. We have PIDs within our budget to create the flexible staffing pool. Also at the ambulatory, we are looking at the top of the nurse license practice and implementing chronic care management visit by ambulatory nurses to improve the patient outcomes through an additional addition of, these are the additional visits we are building. Hopefully we go live with this in June. And CMS provide reimbursement for nurse visits. So this is also an added, patient access, improve the patient access as well as the revenue in those nurse visits. Next slide. So it's, I kind of said, notable quality improvement, all the nurse med sensitive indicators, are improving, and actually, we for the last 2 years, those metrics we sustained the improvement. Provident hospitals, we are increasing the capacity of our ability to staff from 25 to 38. OR optimization project. Also, the CCDPH nursing team implemented the virtual video visit for the home visit to observe the airports visit as well as to compliance with the TB programs. So there's a lot of technology integration within nursing, really optimize the workflow as well as to improve the outcome. Next slide. And from a workforce perspective, we implemented the nurse externship program where we are actually hiring nursing students from their final year, 3rd and 4th years, to be part of our nursing workforce. So as a recruitment strategy, I shared, we have retention committee. We also have a weekly interview process in place. So we interviewed 57 nurses for the last 6 weeks, part of this new program. We also created strategies and structure in place to improve the agency utilization and the management program. Implemented nursing productivity management to make sure that we are utilizing the resources appropriately. And also, we are having an ongoing collaboration with the different colleges within the city, really build our future workforce pipelines. And also, our nursing turnover reports now we have at the unit as well as the entity level. These are the highlights of the nursing, and with that, let me stop. Any questions or comments?
I do. Looks like my colleague, Director Story. I'll defer to you first, sir.
I don't have a question, Director, guys. I would like to just make a comment. As I listened to the presentation this morning from Dr. Peters, and it's just so noteworthy of the reductions when we talk about with pressure injuries, decubiti, and then the bloodstream, urinary tract infection. I mean, these reductions are significant. And I just want to say out loud, it's one thing to say to Dr. Peters, nursing, you're meeting all the challenges clinically, et cetera, but here's the documentation relative to the improvements over the last 3 years. And you need to be complimented out loud for your work, your leadership, and that of your team to make these reductions that are evident in the system today. So I'm very proud and happy to be associated with your work as a member of this board, because this is absolutely good news for our patients and their families. So thank you, and thank nursing. And hopefully we'll say that out loud next month during nursing. When we celebrate our nurses across the board, we really need to make this noted that we are grateful for their support in managing our patients and their families. This is excellent care. This is excellent care.
Thank you, Dr. Story. At the end of the day, frontline nurses are great here at Cook County. They make a big difference here.
Thank you, Director Story. I couldn't have said that better myself. But what I do want to say is, or add to that, is that I appreciate all the effort that's going into the nurse recruitment. I know recruitment in general has been a topic of interest and concern for the HR, or I should say for the board, but also area of focus for the HR committee and the work that Valerie is doing. So thank you for all the efforts that are going into that initiative to try to get nurses on board to the system. Any other questions or comments? Okay, Dr. Peters, thank you so much. Appreciate your
Thank you, Dr.
comprehensive
Garza.
report. Sure. Okay, we're going to go now to an update from the HRO dyad on patient experience. That will be reviewed by Dr. John O'Brien, who's the Associate Medical Director, Medical Education, Ling Dang, the Patient Experience Officer, and Dr. Jacqueline Whitman, who's our Chief Nursing Officer of Stroger Hospital. I'll turn it over to you, the three of you. Thank you.
Great, thank you, Commissioner Garza. And as you heard from Commissioner Garza, it's three of us, and it takes a team. And I think that's probably one of the most important parts of the message you'll hear today. So starting out, we like to talk about how the patient experience really rolls up quite well with our current strategic plan, especially when it comes to what the mission is. So again, when we ask providers, nurses, doctors, why are they here? Why? And that's a really important question to be asking of anyone who's caring for our patients. So many of them talk about the mission. And so as you'll see today, but it takes more than that. And we'll go through some of our initiatives that are helping to improve our patient care. The other thing before we move to the next slide is under values is this idea about caring. And we have lining up with this is with innovation, compassion, accountability, and respect and excellence. We also are rolling out a training program to help all of our providers, everyone from a environmental worker to a physician, do a better job of communicating with the patients. And that's another mnemonic that looks similar. It's called CI Care, and we'll talk about that in a minute. So next slide, please. So of course, the patient experience, we measure, the most important thing we measure is the likelihood to recommend the hospital. And when we look at the Press-Ganey surveys, we really want to look at the top box scores. And as you're all familiar with, when someone's filling out the survey, the choice that is at the top of the box, that's the one that we want. Basically on a 10 scale, 10-point scale, that's the 9 or 10. And so if we look at the Press-Ganey questions, we set up, and we'll look at the next slide. We set up goals based on these surveys and based on what 4-star and 5-star hospitals, how they score. That's what we set up as our stretch goals. And it also helps us to set up our internal goals as well. So this is the likelihood to recommend. And this is the one that's really important for a number of reasons, but so many of the other questions roll up to this. And you can see that we've kind of languished right around what our goal has been, around 75. But in this last month, we've gone up, and we think there's some reasons for it going up. And one of them is this new initiative around communication. But we have several others that we'll tell you about. Next slide, please. This is the doctors, and I'm going to talk about it now, and I'll skip it in my next presentation. It's just happenstance that I'm presenting twice in a row today. So our physicians do a fairly decent job of communicating, and so we're usually around the 80th percentile nationally, and that leads the way here at Stroger, and we're proud of that, but we want to get better. Next slide. And this is the response of the hospital staff. So when someone hits their call light, do they feel like someone's going to respond right away? And you can see here that we are really, this is one that we are still working to perform better on. And one of the initiatives that Dr. Witten will tell you about is the rounding initiative. And we think that that's going to help us with this question on the Press Ganey survey of our response. Next slide, please. Care transitions. The next couple slides are going to be about care transitions. So typically a care transition is when you are discharged. And so did we do a good job of giving you information about how you're going to do things when we're not here to do it for you? And again, you can see that all of a sudden in the last month, it's going up. And we think one of the reasons for that, and again, as I talked about, this is a team. So the patient care team, the patient experience team rather, led by Lynn Dang, who you're going to hear from in a minute, put together a discharge folder. And this discharge folder, we think, is helping us immediately, because this is one of the only things that's new, helping us immediately to raise this score. Next slide. And so you can see here that the discharge information, we've gone up recently, and we're starting to creep up on our stretch goal. I think I'm going to give one more slide before I turn it over. So this will be the last slide. I'm going to turn over to Dr. Witten. So communication around medications. And you can see this thing has shot up. And we really, this is front and center in this discharge folder. So it's the responsibility of the doctors, of the nurses, and even for people in patient experience to go over this with the patients. And again, because it's made so easy within the folder, we think it's already making a difference. And you can see that we've gone way beyond this month, way beyond our stretch goal. And so as it is a team, I'm going to turn it over to Dr. Witten, and she'll walk through some more of the metrics.
Okay, thank you, Dr. O'Brien. Okay, everyone, excited to present on this topic. Hospital environment domain is very exciting for our environmental service workers. So let's put our hands together. You see the increase in as many great things. There's two questions that contribute to this is how often has your room been cleaned, and how quiet is the surrounding around your room, which is collaboration with nursing. But I think there's some great work being behind the workforce, because it has a lot to do with showing our patients that we care and that the employees are happy employees. If you go to the next slide, you see the nice increase under Adam Weber leadership team. But here's what's exciting. Last year, they were at the 4th percentile. Look at the 4th percentile to the 33rd percentile. That is huge increase. And we're going to share some of the strategies that are taking these tactics where we see the nice increase. When you see courtesy of the person cleaning the room, they were at the 1st percentile. Basically, that's sort of saying to me, some people weren't happy in their role, but they went from the 1st percentile to the 33rd percentile. Under his leadership with the frontline team and many other initiatives, go to the next slide, please. We'll show some of the tactics that are really impacting us. Each employee had to focus on their duty list. They had to understand what's important to them and why they're in the role they're in. We also work together to adopt units, to show love to each one, to build relationships between these units so we can connect and build partnership and collaboration. That was really helpful. Rounding tools, rounding and visibility is very important, because you get to connect to everyone, you get to inspect, you get to ask patients how well things are going, are we meeting their expectation? All of this feedback is helping us to drive this. And eventually our goal is, what we would like to do is sustain as you keep seeing the increase. We have daily executive summaries that are led by Mr. Weber and his leadership team. I think what's exciting is the front line have pride in the new uniforms that are navy blue. That's very exciting because that goes along with having pride in what you do and understanding that it connects to keeping the hospital clean, which also helps decrease infections in the organization. But the leadership responsibility zone, how they're tag teaming, making sure that they round on different zones at different times, is also making sure that visibility and accountability is out there, and the standardizing goals, understanding why we're here, what we're tracking, and making sure that that cadence stays in front of us. So I just want to give kudos to the frontline team in environmental service, Adam Weber leadership, and all who's on that team. It takes a village, and I'll show you a little bit later in the slides that whole subcommittee that's making this work. Next slide. I'm very excited about this. I know it's been shown a couple of times, the nursing domain, but we're setting a standard here. I look at it like this, it's 77.67, but we're close to 8 out of 10 patients telling us that they had very good care providing here that they see. And we're going to see a little bit more under the questions, but this is very exciting for nursing. I'm going to share some of the tactics that are helping us to improve, because communication is key to safety first. Go to the next slide, please. As you can see over time, communication with nursing, even mid-month, we were tracking this. You can see the great increase that had the difference between February and January. And these are tactics showing that we're hardwiring. And the only way to hardwire each month is we're looking at this each week. We're looking at reports that we have monthly. If you go to the next slide, you'll see some of the questions that roll up to this. Nurses explain in a way you understand. We have to work with our staff to make sure that they're communicating and connecting to the patient the way they understand, not only the patient, the family. You can see the nice increase from January and February. Go to the next slide. Most importantly, too, when you see this, nurses listen to you carefully. It's important. It's important for the patient to understand that we care. It's important that we demonstrate compassion and empathy. When you go to the next slide, there's a huge focus being done on professionalism here. How do we treat our patients with courtesy and respect? And if you see the nice increase, that's the standard that we want to sustain and even go higher and higher when you see next months to come. So we're looking forward to the tactics that we're doing. If you go to the next slide, you're going to learn more about this. Visibility and rounding is so important. It's important that all of our leaders go in the room and make an impact. We want the families that when they're discharged from the organization to be able to remember and think that a nurse leader did round on me. They did ask me how things were going. They did do service recovery if there was an opportunity for that. But we're showing a nice increase with nurse leadership. We're rounding, we're holding them accountable and molding them to be the best leaders that they can be. Next slide. What's driving these outcomes? I-rounds. Visibility is important. We live it, we breathe it. This hospital operates 24/7. It's important for us to round not just on days, but on evenings, nights, and on weekends. We have a plan in place that we're working very close with our human resources to fill some of our open positions, but we have really hired some top performers, and we're very excited about that. The CI Care is really a connection. How do I connect with the patient? We're teaching demos and helping our nurses to go through training where they understand how to connect with the family. This is hands-on training. Some of it might have to repeat. We're working with all of our families to make sure that they get this correct. And when I say family, I mean our team, our staff, because that's important that we feel we're a family. And if we can make sure that we exhibit that we care with each other, we can connect to the patient and make sure that we are showing that we CI care. And I like the way it rolls off our tongue, CI care. And staff is really embracing this model. And we believe that this is helping us to drive outcomes. More to come. We're also really working with the staff under the leadership, also with Mrs. Spencer and multidisciplinary, many others too, with my leadership team, where we're doing commit to sit throughout our division. We're making sure that people take a moment, breathe, sit down, talk with the patient, make sure you connect with the family. It takes just a few minutes, 56 seconds. We show this video of how you can connect with your family members. Very positive. Bedside shift report is important. We want to make sure we don't lose any information in between as we're connecting with our patients and the nurse. It's important that they get a good handoff. So we're auditing, making sure. What I love is the individualized boards that's in the patient room. It has our name. We talk about the medication. We know the physician. And we work very well in our interdisciplinary rounds with our physicians to make sure that we're connected on the plan of care and that the families understand this. And also, you've heard about the discharge folders. It's just important that when patients go home, they know what the next step is. They know their appointments, their medication. this whole wraparound approach is helping us to move the nursing domain and more to come. Next slide. Okay, at this time, I'm gonna go ahead and hand off to our Chief Executive and Sponsor, Lynn Dane.
Great, thank you. Good morning, everybody. So this is just a slide with the definition of how we ran our numbers for Provident. Next slide, please. As you can see, we still have opportunities to improve at Provident. We are so happy and excited to have a new Chief Nurse Officer for Provident, Mr. Michael Muna, and we are going to collaborate with him and working on some of the HRO work groups that will be equivalent to the work group that we're doing at Stroger. Dr. Witten will touch on those work group when we hit slide 30 and 31. Next slide, please. Still, you know, this is still a good ratio that we have, 85.65 for doctors domain, as in how they communicate with our patients. Again, the truth is most of our patients, if not 99% of our patients, love our doctors, especially at Provident. We started our PFACT community recently with them, and every patient that I hear, they still are raving about our doctors. And so again, once we start rolling out the HRO work group, I'm positive that this number will continue to increase and to stay at least 90th percentile. Next slide, please. Nursing domain, again, you know, as we roll out the HRO work group, we will increase in the nursing domain. We have started training the frontline staff with the CI care training, and that has improved in how patients perceive us treating them with courtesy and respect. But we will continue to roll out training the nurses as well. Next slide, please. And the response of the hospital, as Dr. O'Brien was saying, you know, this is for the call bell. It's also an initiative that we're working on. One of the tactics, we do have Provident under the Press Gang the Eye rounds, and we are slowly implementing that. But again, with the collaboration with the new CNO, we are going to move forward and push for the eye round. Next slide, please. Transition, care transition. We just started implementing the discharge folders for Provident within the last 2 months. So we should start seeing this number going up as well. Next slide, please. Hospital environment, again, John Jordan and Adam Weber are working with their team, and they're doing a great job, and I am very confident that this number will continue to grow. Next slide, please. Discharge domain, again, we're positive that it's going to continue to go upward, and it'll be a trend, and that will hit the 80th to 90th percentile for discharge information domain. Next slide. Increase in communication. We, as Dr. Witten and Dr. O'Brien said, it takes a village. We collaborate with nursing and social workers to make sure that the patients are educated on their medication. And just wanted to share with you, this is the custom discharge folder that we have, and all their medical information will go in here, and it gives us an opportunity to walk them through their medication and just information and their next appointment if they need to know where the location is and the phone number. Next slide, please. Okay, so Dr. Witten's gonna talk on this, the next 2 slides.
Okay, so thank you. How are we getting this done? We appreciate the executive leadership that we do have. I have to raise up a partner, Andrea, that's on the quality team too, that's been helping us. We appreciate that. Each work group has a leader. These leaders are focused, and all of us went through training where we talked about having pride in the role that we do have, having an engaged workforce, focusing on empathy and compassion, but most importantly, remembering that safety is first. So in saying that, each one of these, it takes a village. Each one of these names on this group and subgroup focuses on questions below. If you look at the subgroup, you will see what the cadence is. We can't focus on everything, but what we're realizing is if you focus on just a few things and really hit it right, that's what we're doing and making sure we have the right tactic, and we're using an A3 model to follow through. So just great work. We also have a patient experience report data analyst who keeps focusing, sending us information. We appreciate that. Cassandra is leading discharge, and they're focusing that team on discharge paperwork. And you'll see Denise and Dr. Antman focusing on best practices has to do with care transition. Next slide. Same philosophy with the members. And the next slide, Dr. Izokoli is doing a great job rolling out CI Care and working with Lynn and her team to make sure all the physicians go through this. And as you can see, they're doing a phenomenal job. Mentioned Ms. Spencer, we covered the communication with nursing on what they're focused on, and also talked about Mr. Weber and hospital environment. So to focus it, we're focusing on key tactics to drive so we can make sure that we sustain these goals. Thank you.
Next slide, please. So this is just giving you a current status of some of the initiatives that we started. The community murals, we finished our unveiling this last Tuesday. It was, all three were a huge success. We are rolling out another batch for next year. Our goal is to hit all 17 sites. And then our CI Care standards behavior, the goal is to train 750 staff members per quarter. We are just shy of hitting 100 for the first quarter, and we're having great momentum for quarter two. Leadership rounding, this one we launched in March, where the executive leaders are going to the frontline staff members and on the units, asking them how we can serve them, how we can make their lives better. And we've learned a lot, and it really energizes us as we go out there, because we could see how much they love working at Cook County and how much they love our patients. Quiet Pack welcome kit, we hand these out to new patients. About 40 to 50 new patients daily, and inside the packet, it also reminds our patients to fill out the patient satisfaction survey, and that has helped increase our response rate, among other tactics. And then the customized discharge folder, which I shared with you, this has helped us tremendously. Patients love it because they have all the medical records, all the information in one folder, one location, so that it's easy for them to find. If they come back and they need a follow-up meeting, they just bring the folder back, and even the doctors could help them look through the medical records if they have any additional questions. Waiting areas evaluation. I was able to visit 3 of our sites, and these 3 sites are the 3 sites where we have the highest complaints about workforce violence, where our patients are extremely abusive towards our staff members. And so we were hoping that if we revamp the waiting area, that this will help alleviate a lot of the stress and anxiety for our patients when they come into the hospital, worrying about their symptoms. And so after the evaluation, we are planning on making some minor changes, such as painting the colors in a cooler blue to calm them down, add some plants, add some surrounding nature music or sounds. That has shown, evidence-based shown research that it really does lower the blood pressure. And so there are simple tactics that we could do, which we are going to be implementing soon. Our press gaining eye rounds. Nursing was our first team to jump on the wagon, and they're doing amazing. And so now EVS is joining, physician rounding is on there, leadership rounding's on there, and we are looking forward to expanding it to like all divisions. Employee recognition. This is the Commitment to Excellence Award, and we implemented that in January. And we have awarded over 20 employees at all levels, from frontline to executive directors, and everyone who gets an award are extremely happy, but their departments are supportive of them, and they are too happy for their colleagues. So this will help build that camaraderie, trust, and just a strong community among our staff members. Patient Experience Week is something that this is the first time we're doing it, but it's to help our staff members know that everybody has a hand in patient experience. And so this is also an educational opportunity for our staff. Next slide, please. This is our last slide. Just a few things that are in the pipeline. REST hotline. We recently had a doctor from Duke who came and spoke during Patient Safety Week, and he mentioned about wellness. Wellness is so important, and I know for a fact that Director Otis is an advocate of alternative medicine, and he understands how important wellness is. And so we are also focusing on wellness, because if our staff members are burnt out, they are not going to be at the optimal when they're serving our patients, right? And then well-being actually reduces burnout, that has direct tie to improving quality and safety outcome. And so this is one of the reasons why we're going to start rolling out more wellness programs. And then also Mr. Rocha wants us to hire a system chief wellness officer, because he too sees the value of this program. And that position is going under Dr. Makaitis. And then we're working on the patient family highlight stories. We have patients telling us that Cook County is a top-rate hospital, but you know, we have like this stigma of being a fourth-rate hospital. And the truth is, if we could tell and share the stories of our patients and family for other people to come and visit and watch, they too will realize how great Cook County is. The other thing too is the annual Patient Choice Award. This is us awarding, not us, actually the patient choosing their providers and their nurses, the people they feel deserve an award. So this is going to be like an Emmy, Grammy award once a year. It'll be our first time, and this is it's the most honorable award you could get, because the patient chose you. So more to come, but we just wanted to share with you that we are working hard because we love working here, and we want to make sure that our patients are being treated with respect and with care. Any questions? I think that's all we have.
No, I first let me say that, wow, so many great things going on, and I really appreciate the enthusiasm, and I feel your spirit, the three of you, which I think really drives the power of the science, and it's just exceptional. I'm going to ask my colleagues if there are any additional comments or questions, because we're running on time, and I'll ask that the remaining presenters be brief so that we can get through as much of the agenda as we can before we go into closed session.
I don't have any questions directly, Nazir.
Okay, thank you, Director Story. Anybody else? Okay, well, again, really appreciate the work that you're doing, and just the creative things that you're doing as well, not just the science, but I think, as you said, the simple things that certainly make a difference in connecting with staff at all levels to make sure that they feel supported, so that they're able to feel good about engaging and giving a better patient experience. So thank you for the excellent presentation, and again, your spirit. Okay,
Mr. Garza, can I just add some follow-up?
Yes.
Hi, this is Mari
Yes, of
Ferrer.
course.
thank you so much. In regarding to Tanya's questions in regards to it, screening for depression and suicide risk is universal. Substance abuse screening is completed at the patient's initial visit provider or RN during their annual health risk assessment and during therapy sessions. And the BH team, the behavioral health team, is currently working with ACHN's lead pediatrician to implement a universal substance abuse screening for children.
Well, thank
Thank
you
you so
for
much.
getting the responses. Yeah, thank you for getting back to us so soon. Okay,
Thank
I'm
you.
going to keep
And
the
an
agenda
additional,
going.
oh, I'm
Yes,
sorry,
go
just
ahead.
quickly, an additional consideration would be for emergency room presentations as part of the initial triage for substance use screening at that time. It's been shown to be a critical entry point for the potential for substance use, brief intervention, and initiation of buprenorphine. And I'm happy to talk with you more on the data regarding that. Thank you so much, Ms. Ferrer.
Thank you, Tanya. I will relay that message to the behavioral health team.
Okay, thank you. Overview of the graduate medical education reviewed by Dr. John O'Brien, Associate Medical Director, Medical Education. I think you're on mute, Dr. O'Brien.
Yeah, that'll make it really fast. Thank you for letting me know. So again, I'd like to start this presentation and I'll move very quickly. But again, looking at how we align with our strategic plan. And I'm going to just cover 4 of the strategic pillars. So go ahead with the next slide. First one's going to be workforce. And so just a brief overview on how a doctor gets to be a doctor. They start out in college, they go to medical school, they do a residency. For some people, that's it. They go into general practice, and then other people specialize. They go to a fellowship. Some fellows specialize and go to specialty practice. Next slide, please. What we'd like to do here is we like to look at our workforce as so this entire process. Once someone gets out of medical school, is we like to be thinking about recruiting our providers, our leaders for tomorrow, while they're even here as a medical student working with us as seeing patients. So it's important that every step that they take here with us, that they see that we are a high quality, high safety organization, and that our culture is one of professionalism, teamwork, and we put the patient first. The goal eventually is that we retain these providers as attending physicians, because again, any HR person will tell you that all the time and money that's spent in that first year after you recruit someone, if they leave after that, or if you find out that wasn't a good fit, that's a lot of wasted time and money. And so you've got, for most of these people, 3 to 4 years where both sides are auditioning. Next slide, please. So how do we do in retaining our graduates? Well, you can see here, this is a list of most of our programs, and that for most of them, we are retaining over 40% of the graduates. Where you see it lower here is general surgery and OB-GYN, and that's because we don't have our own programs. We have rotators coming in from Northwestern for OB-GYN and from Rush for general surgery. Next slide, please. Moving then to patient safety, clinical excellence and quality, as well as, well, we'll get into clinical excellence in a second. But for this is about quality and safety. And our residents can, because nearly every patient encounter involves a resident, our residents can provide valuable feedback that can help us to improve hospital performance with relation to patients, as well as our Press-Ganey scores, and as we talked about before. Every single one of our residents is involved in quality improvement, and we oftentimes will use the residents to drive information upwards. So if we know that there's a new initiative around something that we're charting in Cerner, we'll start by informing and teaching the residents, and pretty soon the attendings will figure it out as well. Next slide, please. So one of the ways that our residents participate in improving the care is that whenever there's a mistake that is made, we ask that people report this in our electronic medical error reporting system known as EMERS. And when you look at how our residents make up the total number of people that are reporting, the residents make up 17%, even though they're a small fraction of the workforce. They're making up 17% of all the reports that are generated. Of providers that report, so that includes now attending, they represent 2/3 of all the reports that are generated. Next slide, please.
Hey, Dr. O'Brien, I'm sorry
Yes,
to interrupt. I'm gonna have
please.
to ask you to pick up the pace because we're gonna lose a director here. We need to
Okay.
vote on action.
All right, so
items.
these
if you
are
could
our
just quickly wrap
programs.
this
Next
up.
slide, please. Sure. These are our accredited programs. Next slide. These are programs that are either rotating through or we don't have accrediting bodies for them. Next slide, please. This is citations. We have very few citations. Next slide, please. And this is health equity, the second to last pillar. And this is just showing you that in the U.S., physicians of color make up 5%, Latinx 5%, even though they represent a much higher number of the population. Next slide. How did we do this year in our recruiting? Go ahead, next slide. You can see here that 3 of our 5 major programs recruited more than 50% of their recruits were either Latinx or African American. It's outstanding. Next slide. Okay, and so we have further work to do with some of the other programs, as well as to retain and develop those that we are recruiting. Next slide. Okay, patient experience we talked about already. It's very important, and we keep using our residents to drive the patient experience, and that's why they're all going to be part of the CI Care training. Next slide. This is the action item. We have 4 agreements with outside. So I told you some of the residents rotate in. And so in 3 of the 4 cases that you see here, we pay salary and benefits for those residents to rotate here. One of the agreements, our residents are rotating out, and that institution pays the salary and benefits of that resident rotating out. And that's all I have.
Thank you for that expedited finish, Dr. O'Brien.
Certainly, of course.
Short.
Not at all. Please, let's go. Yeah.
Important. Okay.
Of course.
Okay. Great. So we are going to move on to Dr. Ankintorin's. We're not going to present the information that was already sent down in advance. We only want to present on the items that are for action. So Dr. Wolfman, if you could focus on the actionable items and not necessarily the information that was sent to us in advance, please.
Okay, thank you for that. Yeah, I that's an update, but I'll adjust going forward. So yeah, I think the actionable items are really just vote to approve the credential committee. There's a lot of activity going on with medical staff, new appointments, reappointments, upgrade from provisional to affiliate or full. So that is the biggest main core action item. The QPI report you have, and nothing particularly actionable right there.
Okay, I appreciate that. So we are going to move to the minutes, which were approved by the board at the March meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Okay, it doesn't appear like there are any, so we'll hold that for the combined motion, which we'll move into now. And this will require a roll call vote. So I'd like to entertain the following combined motion to approve the following approve item 4A, proposed clinical training affiliation agreements. Approve item 4C, Stroger Hospital medical staff appointments, reappointments and changes. Approve item 4C, Providence Hospital medical staff appointments, reappointments and changes. And accept item 4D, March 23rd meeting minutes. So can I have a combined motion, please?
So moved.
Thank you. Is there a second? I'll make the second. Any discussion or questions? Okay, I'll take a vote. All those in favor? Aye.
Oh, sir,
I'm sorry.
Chair Garza, I have to take a quick roll call.
Yeah, I'm sorry about that. I moved into a
Sorry,
different-
thank you.
Psychology. Yes, sorry. Go ahead, Deb.
Roll call vote on the combined motion. Director Bott, aye or nay? Director Bott is absent. Acting Chair Garza?
Aye.
Director Sorrell,
Aye.
Director Story,
Aye.
Chair Kim is absent, so you have 3 yeas and 2 absent.
Okay, thank you, Madam Secretary. So the committee will now go into closed session, and action is not anticipated to be taken in open session after the closed meeting has adjourned. So I'll come back to close this meeting once our presentation is completed. So I want to proceed, ask for a motion to go into closed session. Can I please have a motion?
So move.
And is there a second? I'll second it. Go ahead, Madam Secretary.
And Chair Garza, just for the record, to cite the exceptions, it's 1, 11, 12, and 17. Roll call vote on the motion to go into closed session. Aye or nay, Director Bott? Director Bott is absent. Director Garza? Chair Garza?
Aye.
Director Sorrell?
Aye.
Director Story?
Aye.
And Chair Kim is absent, so you have 3 yeas and 2 absent.
Okay, we'll now go into closed session. Thank you, everyone, for your patience and time and excellent work.